Hey, welcome back to Med-Surg Knowledge Nuggets, where we take big nursing topics and break them down into manageable, test-friendly content. Today, we're talking about osteoarthritis. Our first condition we're going to discuss is osteoarthritis, or OA. So OA, by definition, is a slowly progressive non-inflammatory disorder of the diarthrodial synovial joints. It is the most common form of arthritis in this country. There are millions of people that have it, and it's the leading cause of chronic disability. So what is it? So this is a slowly progressive condition. So progressive means it's going to worsen over time. It's slow, so you're not going to wake up one day and you have osteoarthritis. It's going to go slow over time. And it's considered a non-inflammatory disorder, so we're not going to have all of those hallmark signs and symptoms of inflammation. And this affects our diarthrodial or synovial joints. So what are those synovial joints? If you look here in this picture, these are all the different types of synovial joints we have. They are the mobile joints, the joints that allow us to move. So our vertebrae, our wrist, our elbow, our shoulder, our hip, our knees, our ankle, those are all synovial joints. With osteoarthritis, the cause of this is wear and tear. That's going to be the main cause. So if you think about it, we all experience some wear and tear over time because we grow up and we work and we do things, physical things, so we're using our joints. That is normal wear and tear. So why do some people develop osteoarthritis? So osteoarthritis develops when you are doing some type of repetitive motion that puts extra wear and tear on those joints. So for example, your occupation, if you squat a lot, if you reach a lot, if you're using a certain joint over and over, then that is going to develop osteoarthritis. If you were injured, maybe you were in a car accident and you hurt your knee, that injury can progress and develop into osteoarthritis. Osteoarthritis, you become higher risk as we get older. So older age does not cause osteoarthritis. It just puts you at higher risk for osteoarthritis. And that's because over the years, you have more wear and tear. So you're more likely to develop something like that as we get older. So what is osteoarthritis? So we're talking about the synovial joint, and synovial fluid is what kind of cushions the two bones that are coming together to make the joint so that they move freely, kind of like oil, lubrication. And then we have this articular cartilage there that also helps to support that joint. And remember, when the two bones come together, they're not really touching each other. There's always a gap. So over time, when there is breakdown of that articular cartilage, that cartilage becomes soft and less elastic. So it is less able to resist that heavy wear and tear, the use. So the body does realize this is happening, and it tries to repair that cartilage, but it just can't keep up with the destruction of what happens in osteoarthritis. So as the collagen there and that structure changes, that articular surface becomes cracked and worn. The cartilage surrounding that becomes thinner, and the cartilage at the joint edges become thicker. And then these little osteophytes form. Again, this is the body trying to fix itself. The joint surfaces become uneven, and it affects the distribution of stress as we use the joint, and it causes reduced motion. So this can affect mobility. So even though this is a non-inflammatory disorder, you can get inflammation eventually as our white blood cells try to get rid of the small pieces of the cartilage that have broken off from that joint surface. And these can actually cause some inflammation. So these changes, all those changes I just talked about, cause pain and stiffness in osteoarthritis, and that's early on in the disease. But later, once that articular cartilage is lost, then those bony surfaces, those two joints, are going to rub against each other, and that can be very painful. Okay, so let's recap that pathophys that we just talked about. So with osteoarthritis, we're going to have gradual loss of articular cartilage. We're going to have these bony outgrowths that we're going to refer to as spurs or osteophytes at the joint margins. That's our body trying to repair the site. There's going to be unprotected bone where those two bones will eventually start to rub up against each other. There's going to be deterioration of the joint function. This is progressive, which means it's only going to get worse, and there is no cure. And the most common joints that are going to be affected are going to be those joints that are the weight-bearing joints, the knees, the hips, the feet, and the lumbar spine. It could also affect the cervical spine and the fingers, but that's less common. So sometimes even the shoulders and elbows are involved, and that could happen from trauma, like an accident, or maybe sports. Maybe you're a golfer or something like that, and you're repeatedly using like your shoulder joint, then that can also cause osteoarthritis. So risk factors. We talked about why age is a risk factor. Female sex. So once a female goes into menopause, there is decreased estrogen, and that may be the reason why it contributes to more females having osteoarthritis in aging women. Obesity is a modifiable risk factor, and whenever you hear modifiable risk factor, that means you're going to have to include that in your teaching for those patients. And it makes sense that obesity is a risk factor because of all of that extra weight on those weight-bearing joints. So obesity really contributes to those hip and knee osteoarthritis. And then we talked about occupation. And then medications can also affect osteoarthritis. Corticosteroids can kind of leach calcium out of the bones, and it can lead to other bone issues, and osteoarthritis is one of them. Moving on to clinical manifestations. So osteoarthritis can be mild to significant disability. So there's the whole spectrum of pain, and the pain will progress over time. So very important to remember, in osteoarthritis, pain is relieved by rest. So you're working during the day, those weight-bearing joints are being worked, they get tired and they get painful. So once you go sit down and rest for a while, or you go lay down to go to sleep, then the pain should subside. Okay, so that would mean pain increases after exercise. When you wake up, you may have some joint stiffness, but usually it'll be less than 30 minutes or so, and then there won't be any more joint stiffness. And remember, this is specific to osteoarthritis because rheumatoid arthritis is kind of similar, but there are very distinct differences, and this is one of them. Again, with osteoarthritis, pain is relieved by rest, and joint stiffness in the morning subsides after less than 30 minutes. Okay. Eventually, joints can become tender to the touch. Inflammation can occur once that joint deteriorates. You may have some edema. Crepitus, which is like the crunching sound, the crackling sound when you use the joint, could happen. And with osteoarthritis, it is usually asymmetrical. So you can have it in one elbow and not the other elbow. You can have it in one knee and not the other knee. So you can have unilateral. Your body isn't going to be symmetrical when it comes to osteoarthritis. And again, here's our light bulb. Fatigue, fever, and organ involvement is not part of osteoarthritis. This is only affecting those weight-bearing joints. And then lastly, here in this picture, you can see some of these deformities that occur specific to osteoarthritis. We have Bouchard's node and Herberdine's node, both in the fingers. Okay, so when you hear those terms, Bouchard's node or Herberdine's node, think osteoarthritis. How are we going to diagnose OA? So we're going to get a good history and physical. We're going to ask a lot of questions, what's your occupation? What's your lifestyle? What do you do throughout the day? When does the pain worsen? What makes it better? All of those kind of questions. We're going to do a complete head to toe, and we're going to focus on those joints to see if we see those hallmark, telltale signs of osteoarthritis. We can do x-rays, bone scan, CT, MRI. Those are all imagings to detect early joint changes or figure out what stage and how much joint damage there is. And then there is no definitive lab result for osteoarthritis. You're pretty much doing labs to rule out other conditions that may be similar to osteoarthritis. When it comes to management, if the patient is obese, we're going to want them to lose weight. we want to rest and protect those joints. So we want to teach the patient to balance rest and activity. So they shouldn't stop being active, but they should include rest in their routine. We want to encourage rest periods of the affected joint, especially when there is acute inflammation. And you want to keep joints in a functional position with a splint or a brace if needed. However, you don't want to keep that joint immobilized more than 1 week because you run the risk of it becoming stiff because of that inactivity. We can use cold and heat therapy for these patients. So the heat can reduce pain and stiffness. Ice isn't used as often in osteoarthritis because it's non-inflammatory. But if the patient develops acute inflammation, later on in the disease, then ice would be appropriate. But generally speaking, osteoarthritis, you will use hot packs, warm bath, paraffin wax baths. We also want to encourage aerobic exercise. So aerobic conditioning, range of motion exercises, all of those things are aimed to support the muscles around the joint so that it can help with the, take some weight off that joint. For example, we would want to strengthen our core abdominal muscles if the patient has osteoarthritis in the vertebrae, so that the abdomen can kind of take some of that weight off the vertebrae. Surgical management, patients may opt for surgery, or it may be required if the patient is suffering from disability and severe pain that's related to the osteoarthritis. This can be debridement of the area, a surgical fusion of the bone, or joint replacement, like hip replacement, knee replacement, that kind of thing. When it comes to drug therapy, we can offer salicylates, capsaicin cream, that's topical. We can do NSAIDs if there's inflammation, but we want to remember to be careful with those kidneys. Since this is a chronic, progressive condition, you can anticipate the patient being on medication for longer periods of time, so we really want to pay attention to the organ function. Corticosteroids are appropriate, but be careful because we're talking about intra-articular corticosteroids. This means the patient will be getting injections of some type of steroid into the joint itself. So we're not taking systemic meds here. We're not taking something by mouth. It's not going into a vein. This is being injected directly into the joint. And then opioids are an option, but it is last resort. It is very, very rare that a patient with osteoarthritis will be on an opioid. So better just leave that one out. And then you can review table 20.1 in your textbook, pharmacological therapy for the treatment of osteoarthritis. It gives you a nice little overview. Whenever a patient is taking medications for pain, we want to be careful with constipation. So along with this osteoarthritis, when it's going to interfere with mobility. So if they don't have as much physical activity and they're taking these meds, we want to be careful with constipation. Final nugget for osteoarthritis. So the main takeaway for OA is that it is a progressive degenerative joint disease marked by cartilage breakdown, pain, stiffness, and decreased mobility. So we can't reverse OA, but we want to recognize it early, educate the patient on lifestyle changes, educate on medications and supportive therapies that can greatly improve their function and quality of life. Thanks for watching. If this helped clarify things for you, make sure to like, comment, and subscribe for more Med-Surg knowledge nuggets just like this one. See you next time.